if you've responded and, the guy's bleeding to death and you still have a chance of saving him if he gets to a surgeon within an hour. So that timeline is so incredibly important, and it should inform your decision making.
Unfortunately, he's depending on the medic to tell him the information, because I will tell you, from a medical aspect, the 18 Delta is essentially God telling the team sergeant that his echo or whatever will die if he doesn't get him out. And so he has to weigh that compared to the lives of the people on the evac platform to get this person out. That's just current conflict. Not to mention going forward, where you are constantly, just looking at the last podcast from the air doc from the Ukraine, like you are running from artillery fire constantly. So I can't even imagine that aspect right now.
Yeah, I just think there's a lot to be said for the psychological preparation of new medics, that you're going to be in difficult circumstances where you're going to lose people. You're not going to be able to save everybody. And I think that there is a benefit to preparing their minds by telling them that maybe, right, nobody gets enough training, but if you could do FMPs, full mission profiles, where you throw that in, like somebody says, in the Guard, I don't even have enough access to my guys, and we don't do enough training where we have people die on them just so we could get used to them. You lost this guy, right? So we can desensitize them to post-traumatic stress from being a medical provider, that you didn't save somebody's life or your buddy's life. And I don't think we do enough of, like I complained to the pararescue career field, we do a lot of rescue training, but we don't do a lot of recovery training. The FEMA teams put cadavers in piles where they have the dogs find them, but we don't have enough people bagging cadavers into body bags and carrying them and feeling, sort of how gruesome all that is. It really, it's disgusting, essentially. And it's very traumatic to some young people, even if they're cool operators. So I think everything that we can do to, tabletop these things, even if you get something in their head, even if it's just a discussion, hey, you're going to be overwhelmed. Take a deep breath. ABCs, always be calm. You're going to get, slow is smooth, smooth is fast. Keep going through those mantras, but letting them know that they're not failing. They're in a situation where people are going to die. That's just how it goes. Like, not every patient, even if the trauma surgeon stops the bleeding, a lot of those people are going to die of sepsis later, or something like that. So it's important for our health and well-being as medical providers to be prepared for that. And I think that's something that we could do a better job of across all of SOF, which is prepare for failure. And we don't do that enough.
Right. Because SOF always wins. Like I said a while ago, Stacy, you had mentioned that there was a lot of guys coming in on evac that didn't actually need surgery, even though they were declared that they were urgent surgical at the time. I guess how do I determine that this person actually needs surgery? So they've survived the first hour. I've done hemorrhage control. I've done airway, and we're just sifting through this giant pile of stuff. Who actually needs surgery?
Well, the first thing I would say is I don't really see that as a problem. So if they get designated as unstable because they have abnormal vital signs, they need some type of advanced resuscitation, whether or not it's surgery or whether it's just a chest tube, an advanced airway, blood transfusion, everything in ATLS versus an actual surgical intervention. I don't think it necessarily matters. We are looking at, can we put advanced resuscitation teams on the battlefield to help try to stabilize patients or prolong the golden hour